We have with us in the studio some very important personalities who are going to be helping us talk through a very, very important campaign that is ongoing. We all know about malaria, and we know how deadly and dangerous that disease is. And of course, government on its own part, including some non-governmental organizations, have been doing their bit in ensuring that we beat down the rate of fatality and the number of people that we lose, or the amount of money that we lose in treating this very deadly disease. So there is the seasonal malaria chemo prevention campaign that is ongoing. What's the FCT administration doing? What are other players in the health sector doing, particularly for the FCT? Because we understand that other states are also carrying on with this very campaign. So to help us talk through this, we've invited, and we have them in the studio, two very important personalities. I would like to start with a lady, Dr. Aderonke Akonde.
Good morning.
Good morning. Dr. Aderonke Akonde is a public health, is consultant public health physician, and she is also the head communicable diseases from the FCT Primary Healthcare Board. Thank you very much for joining us.
Thank you for having me.
And then sitting very close to Dr. Akonde is Mr. Aliyu Guraguri. He is the Zonal Project Manager, Malaria Consortium. Good morning, and thanks for joining us.
Good morning.
It's good to have you join us this morning. Now, Dr. Akonde, what can you tell us about what, first of all, is chemo prevention when we speak about malaria?
Okay, thank you very much. We all know that malaria is a major public health concern in Nigeria and in some other African countries. So what we are bringing to the people is called SMC.
Okay.
That's seasonal malaria chemo prophylaxis.
Okay.
So from the word seasonal, we all know what it means, either rainy season or dry season.
Okay.
And you know,
that means it's time bound.
Yes, it's time bound. And you know, malaria is also season related. So that's what that literally means.
Okay.
Then we said seasonal malaria chemoprophylaxis. Chemoprophylaxis simply means preventive drugs.
Okay.
So these are the drugs that you give every rainy season period, over a period of 4 to 5 days. And it comes in cycles, and usually given to children between the age of 3 months and less than 5 years. You all know the global burden of malaria is within that age group, and pregnant women. So that is simply the meaning of SMC.
Now, Mr. Guraguri, how is Malaria Consortium involved in this campaign?
Thank you so much for the opportunity. So last year, the Malaria Consortium signed a memorandum of understanding with the FCT administration to implement the seasonal malaria chemo prevention in the FCT from 2022 to 2025. And we started last year, but the coverage of eligible children was way below the WHO recommendation of 80%. We were only able to cover 66% of eligible children last year, but at the beginning of this year, we engaged with all stakeholders, just the Primary Health Care Board, the area councils, and everyone, and we have been able to implement from June to October. We have been able to implement 5 cycles in the interval of 28 days. So currently, the 5th cycle is ongoing across all the 6 area councils of the FCT. And so far, so good. There has been increased acceptance of services. But the areas that we're having challenges are the urban areas of the FCT, especially in Amak, where we have gated estates, military and paramilitary barracks, that we really need a little more protocol to get access. And we have been working with the agencies that are in charge of housing estates in Amak, and there has been increased acceptance. But we are still yet to be where we ought to be. And we use this opportunity to call on residents of the FCT to actually accept these services, no matter how rich people are with these citizens of this country, and anything has been brought by the government or any donor, is their right to actually benefit from those services. So we actually want parents to focus on dealing with other economic issues, paying school fees and utility fees, and let us help them prevent incidences of malaria in their children in the FCT.
So I was going to ask Dr. Akondi, of course, these campaigns like this require a lot of enlightenment. You know, there are a lot of misgivings when it comes to government making available vaccines or drugs for people to come and take. We saw what happened when polio vaccine was first introduced. A lot of cultural and religious insinuations that were brought into discouraging people from, you know, accessing these free drugs. Now he has just mentioned some of the challenges being faced, especially within the urban areas, where, of course, access to some of the homes becomes a lot difficult. How has the FCT Primary Healthcare Board been handling the issue of enlightenment campaign, apart from, of course, the use is platforms like this?
Okay, thank you very much. I must say that a lot has been done regarding the sensitization of the public. We started a lot of community engagement. We had media pally. We had a lot of community sensitization. There were occasions where we needed to, you know, gather all those estates that are inaccessible, all their heads together, even including religious places. So we have to call their leaders and engage them. So we've mobilized a whole lot of community resources that we have. We have a lot of community gatekeepers, including the traditional rulers, the heads of women, the heads of market women, or even the youth leaders. We engage a whole lot of them before we embark in this kind of program. And what we are doing this morning is still part of the community sensitization we talk about. So we go on media, print media, social media. We also have the radios and TV. So we've been sensitizing people to know the importance of getting this prophylactic, this preventive medicine for their wards, in order to be able to prevent them and protect them from the dangerous malaria that is causing the death of our children. Beyond this, we've had a whole lot of engagement as well. And when I say engagement, we come to roundtable to discuss what are the issues, what are the challenges. You know, AMAC is notorious for this kind of thing. Yes, because the problems is actually peculiar to AMAC in terms of unstable population. You know, you get to this estate today, by the time you come back next month, it's already demolished. So, and people are displaced. You can't find them again. Children have to move out. In fact, some of them move back to their state of origins. So those are the challenges we face. So we are able to find means of, you know, accommodating this in such a way that we'll be able to overcome such challenges. I must say that a lot of estates, we have been able to have access to them. We also get involved in their social media platform, like WhatsApp group for several estates. We circulate IEC behavioral communication change behavioral change communication materials. That's our IEC materials. We share them on social media for them to know the importance of getting malaria preventive drug for their wards.
Okay, Mr. Guraguri, I know one of the means of getting people to accept anything that you are bringing on board, I know this is not entirely new, but to some people it will be new, is success stories. Over the years that you've been involved in these campaigns, especially as a consortium, are there success stories that you can share to say these are the things, the good things that will come to you when you know, allow your kids to, or those who are eligible for these drugs, to take them? Are there stories like that that can be shared?
Yeah, you know, so you know, anyone that is investing huge amount of resources in intervention like this will be much interested in seeing the impact that the intervention is. Yeah, outcomes of the intervention. So from the beginning, some of the area councils, we have taken data of incidence of malaria before we started, and now after we implemented last year, we look at data to see, okay, there has been actually some drop in the incidences of malaria in the health facilities. Also, there's an impact story that's also taking place this year, and we hope that by the end of December we are likely to have the results. But generally, based on interaction with community members, our stakeholders, there has been reports of decline in incidence of malaria. And the parents that happen to access these drugs and give to their children have actually been reporting. Even yesterday, we've had stories of parents coming to say, we have not seen these people. When are they coming? Because since when our children started taking it, there has not been incidence of malaria within the family. Yes.
Okay. Sorry, Dr. Akande, you know, although you highlighted it, spending money on treating malaria, how costly is this economic-wise, especially given the period that we are in right now? Will it not be better for someone to just take this drug so that you don't get to spend that much, especially for those families with high number of population?
Yes, I must tell you, it is very costly to treat malaria, particularly in Nigeria we are now, because there's what they call catastrophic healthcare spending.
Okay.
People are already poor. Large populations of Nigerians are poor. So from this poverty, they still have to struggle to deal with malaria burden upon the children, the pregnant women, and so on and so forth.
And health spending does not know that I don't have money.
Exactly, you have to look for that money at all costs. And in most cases, it's about saving the life of your child.
Yes.
Because when complications set in, you don't even care about where you get the money from.
True.
So, and the highest body is among the poor. That's one side. Even those of us that say we are not poor, malaria treatment could tilt you into poverty. Because if you are a father of a child who is below 5 years or 5 years and is being infected with malaria, and there is what we call cerebral malaria, the child could be in coma, could be convulsing. You know, it's a very, very severe case of malaria. In such a case, no matter what your income is, you have to expend it.
Definitely.
Saving the life of this child. So prevention is always better than cure. So that's why we want to implore our people not to wait for malaria to strike. This is a great opportunity. The drug is free. The medication we are giving to children, it is safe, it is free, and it is effective. So in order for you to waste your productive hours in the hospital caring for malaria in a child, is it not better you just give it a shot within first, second, and third day and rest? And you are going to your workplace, making money and living fine, providing for your family at the same time. So that is summary of expenses around malaria treatment.
I see Mr. Guaguri nodding. You want to add something to that?
Yeah, she actually nailed it. I think the economic situation in the country, everyone knows what is happening. So, like she mentioned, the drugs are actually safe. They are effective, and it also creates opportunity for us to actually focus on other productive.
No, you've talked about safety of the drugs, because this is one area where, you know, myths and taboos are usually woven around interventions such as this. And I know the importance and the power that especially traditional and religious leaders hold in this regard. Although you've highlighted some of that, but do you have a a specific plan of engaging these important community members to be able to talk to the people, especially with respect to the safety of these medicines?
Yeah, we get a lot of feedback.
Okay.
And these are the people that has been interacting with our primary health care centers.
Okay.
They are not strangers. Whenever they have concerns, we normally refer them to the nearest primary health care center. So the approach to this intervention is holistic. Okay. So we don't just give the drug and go to sleep. No. We envisage there could be individual reaction to drugs. Okay. But relatively over 95% the drug is safe. And there's what they call adverse drug reaction or adverse events following immunization. Okay. So this is a kind of prevention. So we can use that term for it. Okay. In case your child has a specific reaction to this drug, you can go to the facility. Okay. Some of what we've been getting is just vomiting. Okay. After giving to the child vomits. And I must say that this drug is not unusual. It is the common drug we use for treatment of malaria, but in a regulated dose.
Okay.
Because you can't use it to treat. This is specifically produced, specially for
prevention.
Thank you.
Okay. Okay. You wanted to add?
Yes, so just like she mentioned, there has been series of community engagement meetings at the area council level. We identified 50 key stakeholders in each of the 6 area councils and had them meet at the beginning and discuss about the SMC, what were the plans, what we needed them to do, and we were able to achieve that across the area councils. And they have become like ambassadors of seasonal malaria prevention, and they are involved every month. We implemented through the 5 cycles from June to October. Because this year we were unable to start a little earlier, that's why it's in train November. And it started on Saturday, Sunday, Monday, and then tomorrow. Possibly you might extend. Yes, it might reach Wednesday or Thursday, depending on the coverage, because we recently developed ICT into the implementation to improve efficiency and also effectiveness of the implementation. So we have been making progress. Okay.
I once attended a press briefing by the FCT Primary Healthcare Board. I can't remember which campaign it was, but there was this incentive that was attached to it of sharing noodles to families so that you bring out your child to get immunized, or whatever intervention it was then to get some amount of noodles. Is the Malaria Consortium thinking in this direction, or the FCT administration?
They would like to comment on it.
As a way of incentive.
We call it pluses.
Okay.
We don't actually coerce people to take public health intervention. But you know, the target group for that particular intervention, we call it OBR. That's outbreak response activity in FCT. So usually the children are enticed to pluses, something like sweets, cookies, and all that. But we just felt that noodles was, I mean, it will require cooking, hygienic. So that was why we brought in noodle at that particular time. But usually we don't give incentives for public health intervention. The decision is to the caregivers, the mothers, the parents, the fathers, to decide whether they want their child to have. In case of SMC, which is seasonal malaria prevention intervention in the FCT, we are not giving nodules. We are not giving any incentives. And the decisions are being made based on informed consent from the parents of every child that we see. Thank you.
Apart from your teams visiting houses, do you have centers where those who just want can go and access these drugs? Maybe if your team has not reached a particular house and the parent or the guardian so wish to get the drugs for the kids, are there centers that they can go to across the 6 area councils?
Yes, thank you very much. We actually established temporary fixed post, and we have also a permanent fixed post across all our primary health care centers, even the secondary facility, all the 6 district hospitals in FCT. People can easily access the place. However, the team moving from house to house, they are still in the field. We call them mobile teams. So they move every day within that period. We started from Saturday, then Sunday, Monday, Tuesday. Then we might have to do a kind of mop-up if we feel the coverage is not up to date. So what we need to do is that whenever we see those people knocking on our doors, we should welcome them and, you know, give them much rapt attention to educate us why they need to obtain the malaria medicine for prevention of malaria for their wards.
Mr. Guragu, you wanted to add something to that?
Yes, I think Dr. Akande has actually nailed it. Just like you mentioned, we have 64 health facilities in AMAC that have been deployed to provide the services, the SFC services at the fixed post. And they are all up and doing, they've started. So any parent or caregiver that goes to the hospital for any purpose and they want their children, and the children are negative for malaria, they can actually branch at the service delivery point and take the malaria prevention.
Please, Dr. Akande, I want you to emphasize the fact that it is free, because we know ourselves as Nigerians. We always wait for opportunities like this to exploit each other. I want you to please categorically this time around emphasize whether parents or guardians of, children to be given these drugs should pay any amount of money?
No, nobody is paying for the malaria preventive medicine.
Okay.
So it is absolutely free. Government of FCT and Nigeria is providing it free for every child. And the reason why we are doing this, we know the situation of economy in Nigeria as a country. So we don't want to put a lot of burdens on the expenses of our parents and caregivers. So we are giving these drugs out for free, just like immunization is free. Nobody should request or demand for any amount whatsoever before they could give your child malaria preventive medicine. So we would like to implore our parents, our caregiver, to please accept this drug, give to their children aged 3 months and up to 5 years. So this is going to be a lot of gain for them. And more so, we also practice what we call DOT. That's directly observed therapy, for you to know that it is not for sale. So immediately we get to you and you give a consent, we just dissolve the drug, give to the parent, dissolve in just a teaspoon of a little amount of water. Once you put the drug, it disperses immediately into the water, and the caregiver gives directly into the mouth of the baby, while the health worker observe and ensure that the drug is taken. It's not something you pack and give to people to take home. No. So the issue of selling it or sharp practices and corruption does not exist with SMC. Thank you very much.
Yeah, and I'd also like to use this opportunity to call on people to watch for 2 things. Number one, there are placed banners that are being fixed on the fences and gates of health facilities. And we indicated on those banners that SMC services are free. Then also within the hospital, at the service delivery point, there are also banners that indicate free SMC services available here. So these are 2 signs that people should watch for and ensure that they actually access the drugs without paying a penny.
Talking about signs to watch out for, we live in very perilous times. What signs should parents or guardians be looking out for in the people who come to knock on their doors, claiming to represent?
Thank you so much. This is an excellent opportunity. I am happy that you've raised this issue. So our community volunteers wear reflective jackets that are colored in yellow, and they have written SMC on their chest. Some of them could be carrying their ID cards that can use to actually introduce themselves. I also have supervisors at the level of that specific area, also at the level of the ward, also at the level of area councils. Our colleagues also from the FCT administration, from his care, but also national malaria elimination programs are also going nooks and crannies of the FCT, especially the urban areas, to support the implementation. And we also have our colleagues from the neighboring states that also came to support FCT. From Kogi, we have some. We also have from Nasarawa, in fact, some from Oyo that came to also ensure that the implementation is successful within the FCT. So all these people are going around areas in AMAC especially to ensure comprehensive coverage.
Still staying on that, should I suspect that I don't trust these people to be from your team, what should I do?
Well, so the person actually been given introduction letters from the Department of Public Health that were signed by the Director of Public Health.
Are there like phone numbers that parents can call?
Absolutely, yes. There are phone numbers that have been included in those letters that people can actually call and make inquiries. And also on the banners that we place within the facilities, there are phone numbers that are put there that people can actually call and make inquiries.
So parents, you have it there. You can actually authenticate the people that come to knock on your door to give these drugs to your kids that are qualified to take them. But before we call it a wrap, do you have a target number for this particular campaign that we want to give this drug to so number of children before this number of before
that's also another good one. So last year we had intended to reach 1,094,000 children, 1,094,691 children. But this year we worked on the micro plan and brought it a little down to be a little more realistic. So we have targeted to reach 144,000 children. And through all the cycles that we've implemented. So on cycle 1, we're able to reach 99% of that, with 944,000. In cycle 2, we're able to reach 100%. Cycle 3, 103%. Okay. Cycle 4, 104%. So it is cycle 5 now that we are currently implementing, and we are optimistic that similar percentage actually will be actually covered. But just like Dr. Akande mentioned, the FCT population keeps on changing by the day.
Yes.
And
someone says it's one of the most fluid populations.
Even for the fact that we have reached over 100%, but we are still not comfortable. We think there are so many children that could have been missed. So we are going to the end of the year, and we'll be planning for next year, and we will actually take into cognizance the fact that there has been frequent change in population of children in the FCT. It's unfortunate that the last time we had a population census was in 2006 in Nigeria, but I know the federal government is making effort to also have another census that will give us a better picture of the population of citizens in the country. But I think for next year we'll try to improve on our micro planning, try to consider the influx of people, and in fact whatever factors that need to be considered for us to achieve more children.
Okay, because we still have a few minutes left and we're talking about prevention. Dr. Akande, should people just rely on these drugs? After taking the drugs, you don't do any other thing. For example, you leave dirty water around, you leave your environment unkept. Should we do that? Children have taken drugs, so let's leave all those ones now.
So that's a very important question. Prevention of diseases should be holistic.
Okay.
We all know how malaria is being transmitted.
You will have to explain to us, Doctor.
Yes, from dirty environments. So it is advised that we don't litter our environment with can. We don't leave our gutter lodged with rubbish and with bottled drinks and all that. So we should keep our environment clean, starting from there. If there are bushes around you, ensure that you clear the bush, because that is where the mosquito that transmits the parasite comes from. So beyond the site of transmission, they move into the house. So you have to ensure your household is enclosed and well screened with mosquito nets. In case you don't have the net on the windows, there are insecticide-treated nets that are readily available from government facilities. In most of our primary health care centers, we distribute them, and occasionally during public health intervention like this, we also share insecticide-treated nets for people to be able to cover their beds in case there are porosity around the house. And beyond this, seasonal malaria prevention, as we are presenting, is also key. Even despite all this, the children have to play within the community. They have to go to school, which you cannot control whether malaria is there or not. They will go to worship places, to the mosques, to the churches, and they interact with the environment. So you have to ensure that every year during this rainy season period, be expectant that our health worker should bring this drug, this medication, this medicine for prevention of malaria to your doorstep and be ready to accept it. And apart from this, if you have a pregnant woman within your household, you have to go to the hospital and do regular screening, and so that you can take preventive medicine against malaria. So this is the holistic approach that we should envisage whenever we are thinking of prevention.
Okay. You want
so just to add, to complement the effort of Malaria Consortium, also our donor, the FCT administration procured treatment drugs in the incident that when our community volunteers go to do house-to-house distribution, and they come across a child that has symptoms, and that child is reported to the facility. So when they test that child and found him to be positive for malaria, the FCT administration has graciously procured treatment drugs to be also administered for free. Yes. Yeah, and that's what has been happening from June.
Wow.
Cycle 1 that we have been implementing, and that's really very commendable.
It's really, really,
yes,
absolutely
yes. We procured
commendable.
even testing kits for the facilities and distributors all across the FCT.
Wow.
Yeah.
Thank you very much for what you do for the country. We've been talking seasonal malaria chemo prevention campaign. Of course, it's a campaign that is ongoing by the FCT administration in collaboration with Malaria Consortium. And we've been talking with Dr. Aderonke Akonde, who is a consultant public health physician, and she is also the head communicable diseases FCT Primary Healthcare Board. Thank you very much for being on the show this morning, madam.
Thank you for having
me. And alongside, we've also been talking with Mr. Ali Uguraguri, who is the Zonal Project Manager, Malaria Consortium. Thank you very much, sir, for being on the show.
Thank you for having us.
And it's on this note that we call it a wrap on ASU Morning for today. Till we come your way again tomorrow, do stay tuned and have a blessed day.